Welcome to Cornea Care. We are here with another episode of Systemic Disease and Eye. In our PG days, we used to cram this WHO classification and mostly associated xerophthalmia and keratomalacia with a malnourished kid of poor socioeconomic status. Other causes of xerophthalmia were mostly ignored, particularly if the person looked healthy, as it happened in this case. A 66-year female came with her son. Her chief complaint was gradual loss of vision for last 8 months. And now a week ago, accidentally she had hit her own eye. Since then she was having redness. She was diabetic and cardiac patient for last 20 years, but both these were well controlled with medication. For visual loss, she had consulted 7 months back, where she was told that everything is okay. There is no diabetic retinopathy and routine lubricants were started. When she deteriorated, then another consultation was done, where dry eye was diagnosed and frequency of lubrication was increased. But she felt that despite changing the medicines, she was not improving. On examination, right eye vision was 660. There was no congestion, but I could see a large clump of white mucoid discharge. Conjunctiva and cornea both looked lusterless. Left eye was worse. Vision was 3 meters, there was diffuse congestion, and a cornea had a peripheral epithelial defect of 5.5 by 3 mm size. There was hardly any infiltrate, but significant thinning and hypopyon of 1 mm. Actually, thinning was not corroborating with the amount of infiltrate. Now, considering that the disease was disproportionate to infiltrate and the other eye surface was lusterless, there was a long history of visual loss, it was clear that we are not dealing with a routine case of infective keratitis. So I thought, let me rule out some common causes of corneal xerosis and MEL. SGS was ruled out as there was no lid keratinization, symblepharon, or any such history. There was neither any history of chemical injury nor any features of limbal stem cell deficiency. Sjogren syndrome was ruled out as Schirmer was good and there was no dry mouth or any arthritis or autoimmune disease. When I was digging into her history and asking her so many leading questions, her son told me that mother feels worst at night when she is not able to see at all. It was then that it struck me, is she having vitamin A deficiency? Though she looked apparently healthy and belonged to a good socioeconomic status, I started asking about food intake. They told me that intake is good, but she had undergone a massive intestinal surgery long back. Wow! Now I was able to connect buttocks spots, lusterless cornea, sterile melt, and long duration of symptoms with night blindness. And we started management. Keratomalacia is a medical emergency, needs urgent massive supplementation. So I did not wait for serum vitamin A report and advised vitamin A injection. I preferred injection over oral route in view of gastric surgery. Left eye corneal scraping was done. KOH was negative, but Grams had GPC, GPB, and even few GNB. I never expected so many organisms in this small infiltrate, but it was due to her compromised ocular flora, which happens in such cases. So frequent lubrication was started in both eyes. Moxie 1 hourly was advised in left eye. They were asked to come next day after taking the vitamin A injection, and they were asked to bring the records of gastric surgery. When they came next day, they brought surgical reports which showed that she had strangulated intestinal hernia, which required removal of gangrenous jejunum, ileum, ascending colon, and part of transverse colon. To my utter surprise, I came to know that vitamin A injection was not at all readily available in market. Only chance of getting it was from a dealer near AIIMS, New Delhi, which will take at least 2 days. Good thing is that her son gave capsules of oral Aquasol, which was equivalent to 50,000 international units. Clinically, though, her hypopyon was less, but thinning had progressed to almost a desmetocele, which required glue application. We continued with oral vitamin A. By 3rd day, we got short of vitamin A injection, and her blood reports also confirmed our clinical diagnosis. Her serum levels were very low, 8.68 microgram, way beyond the normal range. There was rapid improvement later on, and at 1 week we repeated the vitamin A injection to improve the liver stores. Gastro opinion was advised so that her proper assessment could be done and other nutritional deficiencies could be addressed. This is how she looked at 1 month with healthy lustrous cornea. Left eye glue became loose, so it was removed. There are many case reports of vitamin A deficiency in adults, and with rise in bariatric surgery, we may see such cases much more frequently. I hope this video helps you in increasing your index of suspicion and early detection of such cases. Thanks for sparing your valuable time.